Welcome to this presentation on the development of a teaching module based on principles of ethics, communication skills, and burnout mitigation tailored to the Indonesian context. My name is Lara Dorgarten. I have a background in nursing and medicine and have completed my master in global health last year at Maastricht University in the Netherlands. And for my master thesis, I was able to join the research project that I'm about to present to you. The research was done with my supervisors from Surabaya University in Indonesia, Dr. Erwin Dia Ayu Masita Devi and Dr. Astrid Pratidina Susilo, as well as Professor Anja Krümech from Maastricht University. So in the next 15 to 20 minutes, I would like to talk to you about our research that started at the later stages of the COVID pandemic, in which Indonesian healthcare workers, like healthcare workers all around the world, faced ethical dilemmas when allocating scarce resources. And many healthcare workers felt inadequately equipped to make those decisions, which led to high rates of stress and burnout amongst Indonesian healthcare workers. But what were the main reasons for that? There were the obvious reasons, such as a lack of medical and ethical guidelines encompassing the specific practical demands of the COVID pandemic, which was similar in other countries since the COVID pandemic has presented an almost unprecedented situation. However, our aim was to find out if there are other factors that are specific to the Indonesian context, which make it difficult for healthcare workers to make those ethical decisions. And based on our findings, we then decided to develop a module on ethical decision making that addresses those problems. Ethics in books and ethics in practice is very different, in my opinion. This quote perfectly shows the perceived discrepancy between the formal education of healthcare workers and their ability to retain and apply that knowledge in practice, that we found during the early stages of our research. So resulting questions were, how can this divide be bridged? And how can ethics teaching be improved to increase its practical usefulness for the students? Those questions led to us developing the teaching module to try to improve ethics teaching in Indonesia and thus also better prepare future healthcare workers for situations like the COVID pandemic, but also other stressful and difficult situations in the future. For the study, we used a responsive evaluation approach, meaning that we interviewed healthcare workers and patients with their relatives on perceived problems in those situations where there was an ethical dilemma. And we used this first step to define preliminary problem statements. Those were then used to draft an outline of the teaching module. And in the second step, we interviewed different stakeholders, which included healthcare workers, educationalists, medical directors, medical students, psychologists, and some more, to review the current state of the planned module. And the problem statements that we identified were, first of all, that physicians were unable to apply biomedical principles in situations of ethical dilemmas due to incomparability with cultural values and a lack or insufficient knowledge of the principles. We also found that physicians lacked communication skills, which led to conflicts with the patients and their families. Lastly, we also found that there was a lack of burnout mitigation and resilience strategies for healthcare workers. However, I will focus on the first two problem statements in this presentation. Regarding the first problem statement, while biomedical ethics are part of the medical curriculum in Indonesia, we found a discrepancy between the formal education of healthcare workers and their ability to retain and apply that knowledge in practice. Other studies worldwide have had similar findings and problematized the lack of structured ethics curricula and practical relevance of taught content, as well as unfitting teaching methods and missing adaptation of ethics to different cultural contexts. So let us take a closer look at those aspects. Current ethics teaching in Indonesia is primarily lecture-based and focuses on factual knowledge of biomedical principles to solve specific ethical problems. However, it does often not focus enough on practical aspects. As reported in other studies, ethics is often taught as a distinct matter, detached from the more biomedical part of medicine, and consequently, as ethics are often detached from the medical context, which makes it harder for the students to connect theory and practice. Even though there has been a switch from lecture-based ethical education towards more active modalities, such as ethical case discussions, the cases are often designed to portray a specific ethical dilemma, and as a result, their transferability to medical practice, with its changing context and other influencing factors, is often limited. And regarding the adaptation of ethics teaching to different cultural contexts, we found that while the general lack of medical and ethical guidelines encompassing the specific practical demands of the COVID-19 pandemic posed problems to healthcare workers in Indonesia and all around the world, for Indonesia specifically, this was furthermore complicated by the fact that existing guidelines are often based on Western values that differ in some respects significantly from Indonesian norms and values. As many of you are probably aware, this is a problem that is heavily debated amongst different scientists. Chattopadhyay and De Vries published an article in 2008 with the title "Bioethical Concerns Are Global, Bioethics is Western," in which they stated that in order to make bioethics global, it must be local. Therefore, we tried to identify factors that might be specific to the Indonesian culture that could pose a problem to ethical decision-making when strictly following the taught principles of biomedical ethics. For example, while the principle of autonomy in many Western cultures primarily refers to individual autonomy, in many collectivist nations such as Indonesia, the individual plays a rather subordinate role to the community. Also, hierarchical structures are really important in Indonesia. People who hold a higher position within the Indonesian society are highly respected, and in cases of resource allocation might be prioritized, or it will be at least difficult for healthcare workers to go against the wishes of, for example, a mayor. Some of our participants, for example, feared consequences when making a decision based on medical judgment rather than choosing a patient in a position of power. Furthermore, when looking at the principle of justice, Beauchamp and Childress state that the principle of justice means distributing resources according to needs. And in cases where that is not possible, material principles must be established, which are properties that define specific criteria for the allocation of resources. Emmanuel et al. In 2020 proposed 4 material principles, one of which is maximizing benefits. Now, maximizing benefits refers to saving the most lives and life years, both of which have been supported by healthcare workers that we interviewed in the previous step of our study. However, while in the case of saving most life years, young people would be given priority over older people, when looking at vulnerability, most patients that we interviewed would prioritize older people due to their physical state and increased vulnerability. The decision to prioritize older people was also driven by religious and cultural norms, including greatly respecting and caring for older community members. This highlights the complexity and context dependability of many ethical decisions, and it also shows that it can be difficult to navigate between what the patients deem right and what the healthcare workers decide. This also underlines the importance of good communication skills, which was another topic that we looked at in our research. And some might say that the biomedical principles already apply to all kinds of different cultures and scenarios when used rightly. But the ethics curriculum in medical schools often does not allow for deeper discussions to a point where there is a deep understanding of the nuances of the principles. Therefore, they are often taken as rules that must be followed, and that leads to conflicts in many situations where there are different belief system or cultural norms. Clinical ethics is seldom a matter of deciding between what is right versus what is wrong. Rather, it involves finding the better, more right, and more reasonable solution among several options. And to enable students to be able to do that and thus improve ethics teaching, we wanted to include other ethical approaches complementary to biomedical principles that might benefit medical students in guiding their decision-making process. Therefore, we included some aspects of contextual and dialogical ethics in the module. The idea of dialogical ethics as part of the procedural ethics could be useful to give the students an understanding of the importance of a situational approach to ethical decision making by seeking dialogue with the stakeholders involved rather than applying pre-existing theories and preconceived solutions. Therefore, we wanted to teach or show the students that what is perceived as the right ethical decision in a specific situation might differ based on the parties involved in the dialogue, even if the situations are similar. That also binds into the contextual aspects of the ethical decision making that we discussed before. Overall, we wanted to show the students that while the principles of biomedical ethics might be the basis for most, if not all, ethical decisions, they should not be understood as rigid rules that can or should be applied to each situation without factoring in other aspects that might influence the decision, therefore making ethics more applicable to the reality of their medical practice. We chose a constructive alignment as the underlying theory of the module to enable the students to construct their knowledge through active engagement rather than passively consuming knowledge taught by their teachers, thus making a shift towards a more student-focused learning setting. We then still included traditional lectures to teach the basic principles of biomedical ethics as well as introduce them to the idea of dialogical and contextual ethics. But then a large part of the ethics module consists of case discussions with cases that represent ethical dilemmas tailored to the Indonesian culture, as well as role play and reflection. Now I would like to go over some of the aspects in regard to ethics that we found in our research. As mentioned before, we once again found that most participants thought that there was a divide between theoretical knowledge and its practical usefulness. Some participants even differentiated between theoretical ethics and practical ethics, which was also the quote at the beginning. However, most participants thought of what they called theoretical ethics as a guiding tool to navigate them through the decision-making process. So ethics teaching was perceived as useful in general. Regarding the active learning methods, as said before, to increase the practical usefulness of our ethics module, we plan to include active learning methods as a main way of conveying the content And participants wanted to further increase those parts and further cut back on theoretical teaching methods. One interesting comment was that by giving lectures and thus also definitions of ethical principles, we would limit the students' ability to critically address and discuss ethical dilemma. Also, to further increase the practical usefulness, the participants suggested to create teaching moments that resemble real-life situations to prepare the students for what they can expect when working in a hospital or any other healthcare setting. So, for example, simulating the emergency unit, a very hectic situation, by adding time pressure, noise, and so on. And then afterwards discuss and reflect on the situation and the decisions made. There were different opinions regarding the complexity of the cases chosen for the ethical case discussions. Some noted that the cases might be too complex for medical students and that we should focus on single principles to help the students understand those principles and not get confused during the discussions. Others said that those more complex cases were suitable to prepare students for their future work. And that was also what I talked about earlier, that this might increase the practical usefulness of the teaching module. Another predominant theme was the need for students to develop cultural awareness when dealing with patients, their families, and also associated people. Due to Indonesia's cultural richness and diversity, cultural proficiency was perceived as a vital factor when navigating ethical decision making. Since many doctors were perceived to lack this cultural awareness, the need to address this in the module was voiced. So, to conclude, I would like to come back to the questions from the beginning of this presentation, which were: how can the perceived divide between theory and practice be bridged? And how can ethics teaching be improved to increase its practical usefulness for the students? At this point, we found that a high amount of active learning methods that imitate real-life experiences as far as possible will most likely be beneficial for the practical usefulness and also increase the perceived relevance of the ethics teachings for students, and thus also their engagement with the module. Furthermore, addressing cultural richness and diversity is important, especially to the Indonesian context. The reported need for cultural competency supports the plan to include contextual ethics in the learning module, since culture is an essential aspect of the context in which an ethical decision is made and communication between a physician and their patient occurs. It also underlines the importance of good communication skill training, which is vital when navigating cultural differences. To help students achieve this cultural competency, a focus on a patient-centered approach in medicine and communication, which includes listening skills, has been found valuable. And this way, the danger of bias and stereotyping is reduced, and the students can apply the acquired skills in different environments and adapt to the local culture, norms, and values. And therefore, we think that introducing the students to contextual and dialogical aspects of ethics will allow for a deeper understanding of the complexity of most ethical problems and could give students more flexibility in addressing them. However, we have had a first trial run of the module in February, which was followed by another evaluation. And Now we will go through the feedback, and afterwards we will be able to see if what we concluded really works in practice and how the module can be further improved. So it is an ongoing process. So that is the end of my presentation. Thank you very much for your attention, and please do not hesitate to contact us if you have any further questions or remarks. Thank you.